All right, so pancreatitis, pancreatic neoplasia. The first, SCORE curriculum, these are the core things that the American Board of Surgery wants you to know about the pancreas. Cystic, pancreatic lesions and neoplasms, both cystic and endocrine and exocrine lesions, and pancreatitis, and that includes acute pancreatitis, pancreatic necrosis, and abscess. The advanced topics, now remember, core topics are 75% of your test. Advanced topics are about 25% of your test. So put most of your energy towards the core topics in the SCORE curriculum. And then once you've mastered those core topics, move on to the advanced topics. IPMN is an advanced topic. And then chronic pancreatitis and pancreatic insufficiency are advanced topics. Autoimmune pancreatitis used to be an advanced topic. It's not even on the SCORE curriculum anymore. You get a freebie there.
So the SCORE, this is like what the American Board of Surgery is based on.
Go to the American Board of Surgery website, SCORE curriculum outline. This is exactly where I get it from. It's free. You don't even need a membership. Yeah. So you go to the American Board of Surgery website, and they have the SCORE curriculum and the outline for the SCORE curriculum, and they break down every single organ and every single disease that they want you to know into either core or advanced.
Wait, just a question.
All right, so we'll talk about, and here's operations and procedures. So not only do they break down disease topics, but they break it down your procedural topics as well in the SCORE curriculum. So this is, again, more for oral board scenarios, but I put this up here for completeness, and they will occasionally ask you about procedural type stuff as well on written tests. So the core procedures they want you to know about in regards to the pancreas: distal pancreatectomy, pancreatic debridement, pancreatic pseudocyst drainage. It's not so bad, right? You guys know that. You guys can do that. Advanced topics: ampullary resection for tumor, easy peasy. Total pancreatectomy, pancreatic ultrasound, Whipple procedure is an advanced topic. And then operative management of chronic pancreatitis. There's like a bunch of different things. They're all great. They're all, patients love them. All right, core pancreas topics. Pancreatitis, so that's inflammation of the pancreas, right? Itis of the pancreas. It's a wide spectrum of disease. It can range from, like I gave the example of the patient who just sat at home and didn't eat anything for a couple days. And some patients have attacks like that, especially chronic pancreatitis patients. They'll tell you, I had 3 episodes last month. One of them I went to the hospital for. They know what's going on. And so it can be mild. It can be a severe, necrotizing, fulminant process that can sometimes end up in death. It can be acute or chronic. Typically, they're going to have pain. That's the hallmark symptom. Majority of these patients, greater than 90%, are going to have pain. Persists for several hours, sometimes for several days. It's epigastric, radiates to the back. Nausea and vomiting in 90% of patients. Occasionally, they'll have dyspnea, jaundice, shock. But pain and nausea and vomiting, the hallmarks. How do we diagnose pancreatitis? 2 out of the 3 of the following: typical pain, elevation of amylase or lipase 3 times upper limit of normal, radiographic evidence. You only need 2. Etiology. Most of these cases, 80 to 85%, are from gallstones or alcohol, though you got to look out for elevated lipids and sphincter of Oddi dysfunction. ERCP pancreatitis, that's the thing. About 5% of ERCPs can cause pancreatitis. And then neoplasms can cause it. Medications, autoimmune, hereditary. But scorpion stings? Watch out for those scorpions. Can cause pancreatitis. Atlanta classification. This is the main guidelines that we go by for the nomenclature, the grading, the diagnosis, the severity. Prior to the Atlanta classification that was started in 1992, all different physicians had all these different names for both pancreatitis and the pancreatic fluid collections, and some of them would call them necrosum, and some of them would call them abscess, and we would see the same thing, but we'd all be talking about different things. So this was, a consensus conference that GI doctors and surgeons and radiologists got together and said, this is what we're going to name these things. And then it was revised in 2012, so we should all be going by these things. Global consensus, universally applicable. So pancreatitis, there's 2 types of pancreatitis. There's interstitial edematous pancreatitis, IEP. That's just pancreatitis. You probably even call it pancreatitis. It's really interstitial edematous pancreatitis. Ask a medical student next time you see them to tell you the 2 types of pancreatitis. They won't know it. You'll look smart. Then they'll learn something. Everybody wins. Necrotizing pancreatitis is the other type. And then the Atlanta classification always helps you to, or also was responsible to grade the severity of pancreatitis into mild, moderate, and severe. And it's basically based on the degree of organ failure, right? And so here's or complications. So here's what we're defining as organ failure. So if they're in shock, if they have pulmonary insufficiency or renal failure, if they have local complications. And then if this is organ failure that lasts 48 hours or more, it's going to be severe pancreatitis. If it's transient organ failure, they come into the hospital, their creatinine's elevated, they're a little oliguric. You give them a couple liter bolus, their creatinine normalizes. Well, they had moderate pancreatitis. It was less than 48 hours. And then it also classifies the fluid collections. This is a big confusing thing that still, people don't follow these. But you will now after this, because I'm going to hold you to it. So, interstitial edematous pancreatitis, diffuse enlargement, fat stranding, as you can see here, homogeneous enhancement, bless you.
Thank you.
Necrotizing pancreatitis represents about 5%, 5 to 10% of the pancreatitis. The hallmark is just kind of patchy and variable enhancement of the parenchyma. So here you can see enhancement of the entire pancreas with contrast. That means that you have to have IV contrast, in order to differentiate for the most part. Because you don't know if there's patchy enhancement if you can't give any contrast. Some patients you can't do this with. If they come in and their creatinine's 5, you're not going to want to give them a bunch of IV contrast dye. And then fluid collections. 4 types of fluid collections based on the time course since their pancreatitis and based on the type of pancreatitis that they had. Acute peripancreatic fluid collections, pancreatic pseudocysts, acute necrotic collections, and my favorite acronym in medicine, WOMPN, walled-off pancreatic necrosis. And this is how we define these things, right? So it's based on the type of pancreatitis to begin with. If they have run-of-the-mill pancreatitis, interstitial edematous pancreatitis, and it's been less than 4 weeks, we're going to call that an acute peripancreatic fluid collection. If it's been more than 4 weeks, we're going to call that a pseudocyst. And typically, we're going to be able to tell that this was interstitial edematous pancreatitis because the collection's homogeneous in both of these things. If it's less than 4 weeks, it's not going to have a very good wall. There's not going to be a good, oftentimes rim-enhancing, recognizable wall. If it's been more than 4 weeks, these pancreatic pseudocysts, they have a well-defined wall, pretty much. Necrotizing pancreatitis, that's going to result in heterogeneous collections because it's not just the fluid and the leakage of the amylase and lipase. It's also just dead pancreas tissue and whatever else the pancreatic enzymes could digest in the surrounding area. And then if it's less than 4 weeks, acute necrotic collection, not a wall. Walled off pancreatic necrosis, WOMPN. After 4 weeks, well-defined wall heterogeneous collection. Any of these can be sterile or infected. You can have an infected acute pancreatic collection. You can have sterile WOMPN. Any of that is possible. All right. I believe in you. Pop quiz. What is this?
What's the time frame?
You don't even always necessarily need to know because the patient said, I don't know. Maybe my pain either started 2 days ago or 2 months ago. Definitely one of those two. Yeah, so this is, I heard someone say pseudocyst. Why do we say pseudocyst? Recognizable wall, right? Homogeneous or heterogeneous? Homogeneous fluid collection, that's right. This is a pancreatic pseudocyst. What is this?
Acute necrotic.
Acute necrotic collection. You guys don't cheat either if you have the answers in your head. Don't cheat. I'm going to shine this in your eyes if you cheat. So this is patchy enhancement. Here's enhanced pancreas. No enhancement there. Not a very good wall. So they have necrotizing pancreatitis and a not recognizable wall, acute necrotic collection. Awesome. What's this? WOMPN. That's right. Recognizable wall, heterogeneous. Look, there's a little bit of darkness, a little bit of light. Patchy. The pancreas doesn't normally start off real large and then get smaller and smaller and smaller and smaller and smaller. This is because there's actually no enhancement. This used to be pancreas down here, but now it's kind of pancreatic necrosis that has turned into walled-off pancreatic necrosis. What's this?
Abscess.
Yeah, this is an abscess or an infected acute necrotic collection. Not a very good wall. Necrotizing pancreatitis, gas bubbles. Not good. Not good. Infected acute necrotic collection. Good job. Treatment, supportive care mostly. It's very frustrating to everybody. They call you, they just want you to fix it. Just fix this pancreatitis. just operate and fix it. It doesn't work like that. It's a systemic disease. You can't just operate on the pancreas and fix a systemic disease. So it's supportive care, aggressive fluid resuscitation, 250 cc's an hour. If they're cardiac, if it's a young person, I'm going to just, soak the bejesus out of them with IV fluids. Until they have good urine output and their vitals are improved, and I want their hematocrit to drop. And then if they're hypotensive, if they're hypoxic, tachycardic, that suggests severe disease, right? That's part of organ dysfunction, so we put them in the ICU for that. Adequate pain control. I'm not in the business of torturing people. And then correct any electrolyte abnormalities. Nutritional support, absolutely essential. We don't starve the pancreas. That's kind of old school teaching. When can people with pancreatitis eat something? When they're hungry. When they say, hey, can I have some meat? Yes, you can. Yes, you can. You said the magic words. Have some clears. Have some, low-fat diet or something. Once their nausea is better, once their abdominal pain, once they start saying, hey, why aren't you feeding me? It probably means you're too late in feeding them. You should have started feeding them already. Enteral feeding, if the MPO is expected for 7 days, so you can give them post-pyloric feedings. You can even give them intragastric feedings through an NG, and enteral feedings are preferable to TPN. And that's been shown in, this is one example of several studies. There's a meta-analysis of TPN versus enteral feedings. Enteral feedings have reduction in cost, reduction in infections, reduction in need for surgery compared to TPN and severe acute pancreatitis. But nutrition one way or another. Antibiotics, often used, not a lot of data behind it. Recent Cochrane review doesn't really prevent infections. Some people still go by that old guideline of, if a third of the pancreas is necrotic, then we're going to give them antibiotics. There's not a lot of data to support that. I don't really start on people on antibiotics. Sometimes if I'm feeling like picking a fight, I'll just stop the antibiotics other people have started, but it just kind of depends. If there's a question, though, the recommendation is to get a fine needle aspirate of the fluid. The benefits generally outweigh the risks of that. Yes, I wouldn't do that every day, because if you're going to stick a needle in them, then eventually you're going to inoculate it. But doing an FNA once, maybe twice during a 2 or 3 week hospitalization, which is often what it's going to be in someone with severe necrotizing pancreatitis, especially if it helps change your management in these patients, the benefits outweigh the risks. And then, our job a lot of times is to prevent recurrence. We're just waiting for the body to kind of get over the systemic inflammatory response. But, we can help prevent any recurrences. And sometimes that means removing the gallbladder. Usually during the index admission, we don't want to allow them to discharge because the rates of readmittance with another episode of pancreatitis is something like 20%. Alcohol counseling, if we think that's it. If it's not gallstones and it's not alcohol, then searching for the other causes of the pancreatitis. And then treating any complications, whether those are pseudocysts or necrosis, pseudoaneurysms, abdominal compartment syndrome, visceral vein thrombosis. So for pseudocysts, pseudocysts for sure, and necrosis to a certain extent. I'm not going to go into a lot of details about these. I'm happy to ask questions, but they're neither core nor advanced topics that they stress a lot about. So we'll kind of briefly go over them, but I'll focus more on pseudocysts. The treatment for pseudocysts mostly is weight. The previous guidelines and the thought process was the rule of sixes, right? So if it's been 6 weeks or it's 6 centimeters or larger, people thought every single one of those had to be treated. But we've learned that that's not the case, and studies that have observed these patients prospectively have shown that people, even with large asymptomatic pseudocysts, may have resolution of their pseudocysts up to a year after this is initially detected. And if they don't have symptoms, it's always hard to improve a patient with no symptoms, right? How are you going to make that patient feel better? They already have no symptoms. So size and time course neither one of those are really an indication for surgical intervention or endoscopic intervention, but it's primarily for symptoms. So those symptoms could be pain. Those symptoms could be recurrent pancreatitis. It could be compressive effects like gastric outlet obstruction or biliary obstruction. It could be an infection, of the pseudocyst, and those are going to be reasons that you'd want to intervene. There's different ways to treat these. There's percutaneous therapy. High recurrence rates, because oftentimes there's still going to be kind of a persistent leak, and you stick a drain in there, or you just aspirate it, and then the pseudocyst just fills right back up. And there's a risk of infection. There's a risk of a pancreatic cutaneous fistula, which is a nightmare to manage. There's endoscopic therapy. This is first-line therapy nowadays. Minimal morbidity and mortality. It's a little operator dependent, but in skilled hands, excellent results, very effective, 90% plus. And then there's surgical therapy if endoscopic therapy is not feasible or fails. So what does endoscopic transgastric drainage look like?